Yep.
All righty. We are going to welcome all of our participants into our session 2. We're going to give everybody a minute to kind of come on into the room, and then we'll get started shortly. All right, while we're waiting for everybody to join, we'll go ahead and get started just with our introduction. So this, let's see if we
can you just click on the slide? I think it's just not connecting to the PowerPoint.
There we go. All right. So welcome back to our 2021 Bonheur Back to School Diabetes webinar. This is our session 2, where we will be going over new onset diabetes diagnosis, as well as follow-up with some additional resources as well. I think this was originally titled as a provider presentation, but today we're going to have our subject matter expert, Ms. Madison Greer, present a lot of information for us. So we're super excited. Just a few ground rules if you guys weren't at the session 1 time. All of our questions are going to be manned through the question and answer section. Make sure that you send those. We actually didn't get any questions the last session. So just as you have a question that you think of, go ahead and put it there. Even if you have a question from a previous session, you can also put it there, and we might hold that question for the end of session 3. We also will not be using the chat feature or the raise hand feature. So those are not part of this webinar. Just if you were looking for those, we're strictly using that question and answer section. And then questions will be answered during and at the conclusion of this presentation if time allows. If maybe your feed cut out and you missed what someone was presenting, we might be able to just send you a message right back with your answer to your question. But if you've got a question that would be really great for a greater audience to hear, then we might hold that question until the end of this session or the conclusion of session 3. So we are also, just want to let you know, we have no potential conflicts of interest to disclose in this presentation. All of these presentations are just a sharing of knowledge from our clinic staff here at Bonheur, our education staff, just so that we can really provide the best care to patients all the way around. We're very grateful for everything that you guys are doing on the front lines for us. They're taking care of kiddos. And we hope that today you can learn a little bit more about what goes on behind the scenes on our side, as well as what goes into the intricacies of diabetes and different diagnoses. So I'm going to hand it over to Madison to present next.
Hello, everyone. So I'm known for going a little too fast, so I'm going to try and go pretty slow on this so that we can get everything covered. Initially, we did have a provider planned for speaking on this, and then they all went on vacation. So I got luck of the draw to teach on diabetes pathophysiology, and we did get some input from them as well, just to make sure that it went along with what our providers would like for y'all to hear as well. So my objectives today are going to be to discuss the pathophysiology of type 1 and type 2 diabetes. I am going to mention a few of the more non-classical forms of diabetes. We will discuss diabetic ketoacidosis course and presentation, and refer to that as DKA most of the time. We're going to discuss hyperosmolar hyperglycemic state, which is called HHS. That's something that you might not have heard of before, but it is something we're seeing happen a little bit more often in our kids, so we want to talk about that. And then I'm going to discuss some identification of diabetes warning signs, and you'll kind of see how that's used in just the general population of school and not our kiddos that already have diabetes. So before we really get into what causes type 1 and what causes type 2, I always think it's really important to kind of see what the big issue is in diabetes. So this picture, we do use this in one of our classes. And so the top picture, I don't love that it says normal, because we know that our kids with diabetes are normal as well. They're a child with diabetes, but they're a normal kid. So I don't love that, but other than that, this is a really great picture of how the body works in diabetes versus how the body works without diabetes. So here's my pink panther up at the top. He has got the perfect amount of insulin production. His body is using it perfectly. So what happens is anytime he eats food, that stomach, small intestines, that whole GI system breaks that food down into sugar or glucose. From the small intestines, that sugar does enter into the bloodstream, and the bloodstream carries that sugar all throughout the body. So everywhere in our body uses sugar for energy, whether that's the brain, our muscles, our heart. It's really very important. So the bloodstream carries it all throughout the body, but for it to actually move from the blood into the cell, that's where insulin comes in. We most of the time refer to insulin as a key, might be called a bridge. And what it does is it pulls that sugar from the blood into the cell so that you can have the energy you need. So in this pink panther that does not have diabetes, all of that sugar is being used for energy. None of it's coming off in the urine. Another thing that happens that we don't talk about as much in diabetes is that the liver is consistently producing sugar, and that when someone eats food and their body starts producing that insulin, it actually blocks the liver's production of sugar for a period of time. So you've got kind of a double whammy when it comes to diabetes, which you can see in that bottom picture. This bottom picture, you kind of see this in type 1 and type 2 diabetes. That pink panther has no energy. He has no insulin, or the insulin is not working properly. So he's still eating because his body says, you need energy, eat something. So the stomach, small intestines, they're still doing what they need to do, pushing that sugar into that bloodstream, but you have no key, no bridge to pull that sugar into the cell to be used for energy. So they end up peeing a lot of that sugar off, and then they switch over to some fat breakdown, which if you were in our first session, you learned a little bit about that with ketones, and we're going to talk more about that today in this presentation. So we'll start with type 1 diabetes. So we know that type 1 diabetes is the autoimmune destruction of the beta cells of the pancreas. That means that the immune system, our own immune system, kind of turns on us, and it goes and it destroys those beta cells in the pancreas. The main thing that beta cells do for us is they produce insulin. So in type 1 diabetes, we're going to have no endogenous insulin production. Every bit of insulin that the person with diabetes receives is going to come from injection, whether that's with an insulin pen or an insulin pump. The reasons why this autoimmune destruction happens is not perfectly clear. We do see that it is multifactorial, and we know that there is a genetic propensity. So it does start with genes. A specific gene that we actually see a lot associated with diabetes is the HLA gene, even though there are some others as well. I always tell my kids and their parents in class that everyone in there has that gene, just the person at risk for diabetes, that gene is coded inappropriately. And so that's why we're not completely sure what's going on with diabetes. We know that you can actually have that gene with an inappropriate coding and never actually get diabetes. So we see that there has to be a trigger as well. Viruses, we think, could be a trigger. We might see certain things in the environment. At one point, we thought that a stressful event in life could lead to a diabetes diagnosis, but now we're not as sure. This is where that kind of confusion about what causes diabetes comes into play. We know that there's genes and triggers. We just don't really know exactly what serves as a trigger and why that serves as a trigger. Type 1 diabetes can develop at any age. This is something that might surprise a lot of people. We think about type 1 diabetes as diabetes of the young. It actually used to be called juvenile diabetes, but we saw that it can develop at any age. That is usually before 30, so we had to change that name. So it's been called type 1 diabetes for a while, even though it used to be known as juvenile diabetes. So that's just a little bit about pathophysiology of diabetes. One thing that will come into play, especially for you as school nurses taking care of these patients, is this thing called the honeymoon phase. So the honeymoon phase, this is something that occurs shortly after diagnosis of type 1 diabetes. And during this phase, the person with diabetes might need less outside insulin. The reason for this is generally that diagnosis of type 1 diabetes comes before we see complete destruction of the beta cells. So once we start someone on treatment of insulin, those beta cells that have been kind of trying to keep up with the full insulin requirements of the body, so probably 10 to 20% of those cells that we should have, they've been trying to do all the work. So diagnosis, they've finally given out on us. They have been trying and they just can't keep up. So I always kind of say that they kind of get to rest once we start that insulin injections. And so once they've rested, they do decide to get back to work. They start producing insulin again. That insulin might be pretty consistent. It might be given at appropriate times, and you see kind of a consistent lessening of insulin requirements. But you also might see just random lows. The pancreas might just kind of spit out insulin at some random times, not those appropriate times that we need. So we might see some low blood sugars that we can't really explain. We don't really test to see the end of the honeymoon phase. We just kind of guess that it's ending because we start seeing an increased variability of blood sugar levels and increased insulin requirements. This phase does generally last about 3 months to 1 year. The younger the person is that is diagnosed, the shorter the honeymoon period normally is. So our younger children come out of that honeymoon phase a lot quicker than some of our older kids. And you might have even seen a child that had a honeymoon phase longer than a year. They might be 2 years past diagnosis and still only need a long-acting insulin. That is something that we do see, but it's kind of out of the ordinary, not something we're expecting. Usually about a year in, they're going to be needing all of that insulin via injection. So type 2 diabetes is very different. It's characterized by insulin resistance. The person with type 2 diabetes might have normal, increased, or possibly decreased endogenous insulin production. So you can just have a full variety of what's going on in type 2, but the big thing is insulin resistance. Insulin resistance is a body thing that's going on. It's not that the insulin is not working and not trying to do its job. It's that the body is not letting the insulin do its job. It's there, it's trying to open the door of the cell. It's like you got a rusty key, it's going in and it's just not opening the door, even though it's trying to do what it needs to do. So that's what we call insulin resistance. Again, type 2 diabetes is multifactorial. So there's no clear answer in diabetes, which is something that's really fun for our patients as well as for us here at Bonheur. But we do see that there are a lot of factors that go into that risk for type 2 diabetes. It starts with genetics, very different from the genetics of type 1 diabetes. So in type 1, talked about how that HLA gene can be there and not actually cause type 1. A lot of our kids with type 1 diabetes, they have no other family member, or it skipped a generation. Type 2 is very different. If you get diagnosed with type 2 diabetes, I would be very surprised that you did not have any other family members with it. You're probably going to see aunts, uncles, siblings, parents that have type 2 diabetes. We do still want to think about lifestyle, whereas we used to think that type 2 diabetes was completely a lifestyle illness. We do know that that still plays a role, even though we have seen really the role of genetics increase in how we see type 2 diabetes happen in our population. So that would be our healthy eating versus our unhealthy eating, and our sedentary lifestyle versus an active lifestyle. Those not as healthy lifestyles are going to lead to a lot of times weight gain, which is going to lead to a little bit more insulin resistance. So we can often see just lifestyle changes really helping with that insulin resistance. Certain ethnicities are more at risk for type 2 diabetes as well. That really plays into that genetics. But we really do see that it's going to occur a lot more in maybe our African American and our Hispanic American populations than the Caucasian population. Gestational diabetes. This is a temporary form of diabetes, one of our only temporary forms of diabetes. So that is when you have diabetes while pregnant. And once that baby comes out, that diabetes goes away, but it does show that we can actually see an increased risk later on of getting that full diagnosis of type 2 diabetes. This also is going to put the child of that pregnancy at risk later on of developing type 2. So it's not just the mother with diabetes, it's also that child of that pregnancy. Another thing that can often lead to a type 2 diabetes diagnosis is polycystic ovarian syndrome. That is for a female issue, of course, and we have a bunch of cysts on our ovaries, and what that does is that actually causes insulin resistance, which is the big thing with type 2. So we know that that is going to increase our risk as well. Type 2 generally develops at any age, but it is usually after the onset of puberty. We are seeing an increase in type 2 diabetes in children. So a few years ago, very small percentage. Now we're really seeing at least half of our diagnoses coming in and being type 2. So we're seeing that this is going to be something really occurring in our younger population as well, versus how we used to see it as more of an older population issue. So just a few other types of diabetes I do want to mention that you might see. Cystic fibrosis related diabetes. This goes along with a cystic fibrosis diagnosis. So generally what happens in cystic fibrosis is you see just an overall thickening of the body's different fluids. And so with that, we can actually see some scarring in the pancreas and a decrease in that insulin production. So a lot of our children with cystic fibrosis and our adults with cystic fibrosis will eventually get a diabetes diagnosis just related to the whole picture of CF. Another type of diabetes that we see is monogenic diabetes. So this is one specific gene being altered and leading to a diagnosis of diabetes. So very different from type 1, which is multifactorial. This is related to one gene going wrong. They have identified at least 9 separate genes that can cause monogenic diabetes. You might hear this called MODY or neonatal diabetes. So depending on which gene causes the diabetes, it can change treatment. Unfortunately, insurance does not love to cover these genetic tests that can really show us which type of diabetes it is. So a lot of times you just kind of have to guess that this might be a monogenic form of diabetes, and we might have to just try some different ways of medicating. For example, there is one specific monogenic diabetes that is treated very well with a sulfonylurea, which is generally a type 2 diabetes medication that increases the pancreas's production of insulin. So in one of monogenic diabetes, we can treat it with that, but everyone is different. Unfortunately, we don't get that testing super often to see for sure which one it is. Hopefully in the future, we'll see that a little bit more. And then we also see some medication-induced diabetes, really gestational diabetes and medication-induced diabetes. Those are my only diabetes that really go away. Excuse me. So medication-induced diabetes, steroids, certain psychotropic medications, a lot of times those just lead to higher blood sugars, needing an increase in insulin. So we might have to treat for that. Generally, if we come off the medicine, we might be able to see a reversal of that diabetes, but sometimes those medicines are more of a long-term cure for something else going on. So we're going to consistently have that diabetes. And sometimes those medications do permanently damage the beta cell production of insulin. So we might have that long-term, even if we come off with those medications. So now we'll move on to talking about diabetic ketoacidosis, or DKA. So this is something that you as nurses are probably very familiar with. You've probably seen a student that is in DKA. So we really want to talk about kind of what is a precipitating event, what it kind of looks like, and how we treat it. So with diabetic ketoacidosis, this is seen in type 1 and type 2 diabetes. So we do generally see it more often in type 1, can be seen in type 2. So the big precipitating events for DKA are going to be inadequate insulin or excess hepatic glucose, or a combination of the two. So inadequate insulin, that might be related to the non-adherence of the patient to taking their insulin when they are supposed to. It might be related to them not feeling well and feeling like, hey, if I'm not eating my food, I don't need to take my insulin. We know that that is not true. It might also be related to excess hepatic glucose, which certain illnesses, excessive stress, those are going to lead to the liver producing a little bit more glucose than it normally does, leading to higher blood sugars where we really need that little extra insulin to get that blood sugar down and prevent the formation of ketones. So why does inadequate insulin lead to ketone production? I think that's the big thing to think about. So with insulin, we talked about how it enables us to use the sugar from our food to have the energy we need to do our daily tasks. So if we do not have the right amount of insulin, we don't have that match of sugar to insulin, that sugar in our bloodstream is going to, of course, rise, but we're not using it for energy. So our body does have a backup. It breaks down our fat stores to get the energy that we need. That is supposed to be a good thing. I always tell my patients this. Fat breakdown is not bad. My example is always Saturday morning. Tomorrow morning, I am not going to wake up at 6:30 and eat my breakfast. I'm going to sleep in because it's Saturday, which is perfectly fine. My body is going to switch to that fat breakdown until I wake up and eat something. And by the time I wake up and eat something, I'm going to get my insulin. I'm going to be good to go. I'm not going to have a buildup of ketones. The problem is when that goes on for too long. So if that continues, those ketones are going to build up and we're going to get some ketosis. So onset of DKA can be anywhere from 4 to 10 hours. So it is a pretty quick process. I believe if you watched the previous presentation, Maggie said, hey, we want to treat this early because we know that it does quickly build up and we can get really sick. So things we're going to see with diabetic ketoacidosis, very first thing we're going to see most of the time is that hyperglycemia. So high blood sugar. We might see some of those symptoms of highs, that polyuria, polydipsia. There's a few more of those listed on this underneath hyperglycemia, but we kind of already know what that looks like in our patients with diabetes. They're going to also see some dehydration. If you think back to my Pink Panther photo, you saw that the kidneys are actually flushing out some sugar and they're also going to flush out some ketones. So we might see some dehydration if this is not treated quickly. Dehydration leads to some electrolyte abnormalities as well. So we might see them saying, I've got some muscle cramps. I feel like my heart's beating really weird. So could be some of those signs that we see. If we don't address those early signs, that hyperglycemia, that dehydration, then we're going to start to see some ketosis where that ketone buildup happens. Ketosis, we do know that ketones are an acid. So that's going to lead to that acidosis. We know that the body wants a certain balance of acids and bases. So if we get that buildup of acidosis, it's going to mess up a lot of other things as well. So we're going to get very sick if we don't go ahead and address that. Some signs that that's getting kind of worse, we might see that fruity acetone breath. That's related to this thing called Kussmaul respirations. Some people can't actually smell that fruit on the breath. So sometimes that kid might walk into your office and you're going to say, that person has ketones. That happens in our clinic. We walk through the waiting room and we'll think, someone in this waiting room has ketones, because you can a lot of times smell it on their breath. And with the Kussmaul respirations, their breathing starts to get more rapid, more shallow, and that is actually the body trying to breathe off that acid. So those are Kussmaul respirations. Generally a later sign, and by that point in time, things probably aren't great. So to treat diabetic ketoacidosis, we want to do a couple of different things, and those things serve completely different purposes. So we don't want to choose one over the other. We want to do both. So insulin is my first step that I want to do. I want to treat those high blood sugars. What that's going to allow my body to do is it's going to allow the body to pull the sugar into the cells to be used for energy, which is going to lead to the body no longer breaking down fat. So that's helping us to stop ketone production. The hydration is going to serve a completely different purpose. It is going to help us to flush out what has already formed. So we want both of those things. You have probably talked to a parent that said, oh, they have ketones, but I gave them lots of water and it got rid of them. It's not going to, in the long term, get rid of them, because if we don't also take that insulin, they're just going to continue to build up. So we really want both of those things together to treat diabetic ketoacidosis. So very important. I always tell our families that if we see ketones, so we check if our blood sugar's high, we're sick, something like that, we want to go ahead and treat as soon as possible, but we're not going to just assume that that got rid of them. We have to retreat, we have to recheck, see what's going on. To learn a little bit more about exact ketone treatment or sick day rules, if you want to refer back to our first presentation, those will be available. It's going to go into a little bit of how often, what we're going to actually do for each level of ketones. Generally, ketones aren't going to occur too often if we are compliant or adherent to our medications. But that does not mean that if we see ketones, we're going to just assume that our child is doing something wrong or the family's doing something wrong. We do know that the risk of DKA is greater if we have some kind of illness going on. So if we've got the flu or we've got a stomach virus, our risk is going to really go up. That risk of ketones is going to be elevated even if our blood sugar is in range. That is why we don't just check if we're greater than 250. We also want to check if we don't feel well, because we do see that we can have normal blood sugars and have ketone production when we are sick with something else going on. So that means it's going to be very important that we take our insulin even if we're not eating. So that is that long-acting insulin. That long-acting insulin really focuses on the liver's production of sugar, which we've seen in DKA is a big part of this, that the liver increases that sugar production. So we still need that long-acting insulin. So we definitely want to take that. We want to be checking our blood sugars and correcting as needed. If we are seeing normal blood sugars with some elevated ketones, we do want to try and bring that blood sugar up so we can get some insulin so that we can stop production of ketones in the body. So with that, we might suggest some hydration with fluids that contain sugar. That might seem a little bit weird. We're actually trying to drive the blood sugar up so that we can give some insulin because we see that it's so important. So that's a little bit about diabetic ketoacidosis, something we're going to see really most often in our children with diabetes. Now we're going to talk about this thing called the hyperosmolar hyperglycemic state. So hyperosmolar hyperglycemic state, this is usually seen in type 2 diabetes, not very often in type 1 diabetes. Precipitating events are going to be different than that DKA. We are going to see a severely elevated blood glucose level, and it's most often related to decreased water intake or lack of access to fluids. So dehydration is a huge thing with this hyperosmolar hyperglycemic state. That elevated blood glucose a lot of times in HHS is going to be significantly higher than the blood sugar in DKA. So this is when we're going to see those blood sugars in the thousands. So it's going to be a very high blood sugar. So severe hyperglycemia, we see profound dehydration. We're going to see neurologic changes a lot earlier in this HHS. So lethargy, confusion, something that's very different from DKA as well. We don't see significant ketosis. You might see some small ketone amounts due to starvation and dehydration, but it's not as related to the need for extra insulin. So that means treatment's very different. Treatment for a hyperosmolar hyperglycemic state, a lot of times hydration and correction of electrolyte deficits, it's going to be our only treatment. We might need insulin, but a lot of times just having those IV fluids, it's going to bring that blood sugar down without even the need to give extra insulin. This is something that we are going to come into the emergency room for. This is not something we treat at home. So we definitely want to see someone in HHS be sent immediately to the hospital. So if we are concerned for this, we see that super high blood sugar, we see some of these signs, that is an urgent concern. We definitely want to talk to the clinic, come into the ER so that we can get the treatment that we need. And then my last thing that I just wanted to show y'all, this graphic is from beyondtype1.org. It's an amazing website, really great resources for young children versus older children. It's got guides on things that as your kids are getting older, like alcohol use and diabetes. It's just a wonderful website. One thing that they are doing in particular is this is called their DKA prevention campaign. So what they are trying to do is they're trying to address those warning signs of type 1 diabetes early. We have seen that a lot of times type 1 diabetes is misdiagnosed. Those signs of the beginning stages of type 1, excessive thirst, frequent urination, unexplained weight loss, being exhausted all the time, those can be easily missed. So we really want to step in early if we see those symptoms. So you want to immediately tell a parent if you see those signs, hey, take that child to the primary care doctor. We need to check this out. See at the bottom how it can be mistaken for flu, stomach virus, or just a growth spurt. It's so easy to miss. So these signs that they have, they actually are spreading these out to different primary care doctors throughout the country. Could be a useful thing that you could download even and put in your nursing office. It comes in English and Spanish, which is super awesome because we talked about how diabetes, especially type 2 diabetes, is actually a little bit more common in the Hispanic population. But we also see a lot of our people that speak Spanish really coming in with type 1 diabetes as well. So I love that they have both of these available. So if you wanted to download that, you could go to beyondtype1.org/DKA campaign to get those signs for free. And there are my references.
All right, thanks, Madison. She did a great job explaining all of that. We really wanted to bring this information to you guys because you guys are the ones that are first noticing those things, as Madison was saying. Noticing that something is off with a kid, and even teachers and educating teachers, because they're going to see kids day in, day out and notice when some of these changes are occurring. And so we definitely wanted to give you that information. I'm going to talk for a little while about our new onset education process and follow-up, just because it does impact the school care plan and the orders that are coming to you. And it kind of, I think, is beneficial for you to know where the patient is in their new onset process, because we consider a new onset diabetes diagnosis as a process. So I'm not going to read these slides word for word, but if you registered before Tuesday, then you got an email with these slides so you can take a look through them. But the biggest thing is that our on-call doctors are going to review referrals from either outside EDs, primary care doctors, and our Bonheur emergency room. And then they're going to determine if that child is a higher acuity patient, if they're unstable and really sick and DKA or HHS, as Madison was talking about. Those patients are going to typically be admitted to the hospital. If they're from an outlying ED, I know we've got some people from Arkansas, Mississippi, and other places on our calls, then sometimes they're transferred here to Bonheur for that admission stay. A few other reasons that they might be admitted to the hospital could include if they're COVID positive patients right now. We don't know how that will pan out in the future, or other medical or social concerns. But if patients are stable, if they're not in DKA, then they'll be scheduled for a new onset diabetes session in our clinic. And so I'm going to go through a little bit about what that's going to look like. All the patients who are admitted as an inpatient on their very first diagnosis of diabetes will get their education over the course of the inpatient stay. Education overall for these new onset patients is provided by both a nurse and an RD, so our registered dietitians. And we're actually going to have our registered dietitians present in just a little bit, but very much key to everything. Inpatient, like I said, and then outpatient happens over 4 to 5 hours in a classroom here at our downtown location at Bonheur. So again, we have clinics in Tupelo and Jonesboro and Jackson, Tennessee, but those locations do not have diabetes services. So our patients who come for diabetes services are going to be at our Memphis locations. And for this initial education, it's going to be at our downtown location. Again, families will receive the education I'm going to talk about in the next slide from a nurse and a registered dietitian. These are our topics that we go over in day one. The biggest thing that I think we want to just share with you is that diabetes is a lot. There's a lot of information and it all builds on top of one another, just like your curriculum within school as well. And so we start with the survival skills. How do we get them home safely? And so you'll notice on here that we are only going over this basic understanding of diabetes, and we're hitting the high points and making sure they know how to handle low blood sugars, they know how to handle high blood sugars, but they're also communicating heavily with the clinic at this point. So as we go through these topics, they're calling the on-call doctor every single night for the first 7 days to report their blood glucose values, and also for us to touch base, because on that first day, it's quite overwhelming with all the information, and there are sometimes a lot of emotions that families face on these days. So we definitely are going to be following up with these families. So these are the topics that we're going to go over, and they're going to get these topics whether they're in the hospital getting their education or whether they're on the outpatient side getting their education. It's standard throughout. They also receive a diabetes education notebook on their first day of education, again, either side, and that has all of this information in it and more as it builds throughout the classes. And so that's really great for them to refer to. We don't expect them to be able to say the rule of 15 right off the bat. We just need them to be able to go and find that within their curriculum, within their binder that they have. And so if they don't have an answer for you, oh, I don't know how to treat a rule of 15. Well, oh, hey, you've got that binder, right? Yeah, we've got that binder. So we definitely want to refer them back to that so that they don't feel defeated as they're absorbing so much information with the new diagnosis. And so, one thing too, and I think we've already kind of talked about it, so in the previous session, but most patients that need mealtime insulin are going to be started on a sliding scale with that rapid acting insulin of Humalog or Novolog or Apidra or Fiasp. That's all those brands are determined by the insurance. But for the most part, a patient's going to come to you with a sliding scale, and then they might transition to needing dose calculations later. A few patients, whether it's a very young patient or maybe a patient with some specific eating habits or something that is concerning, they may be on dose calculations from the beginning. But for the most part, these patients are going to come to you initially with a sliding scale insulin dose. These insulin doses are determined by their age, weight, puberty status, and insulin resistance, and they are tailored specifically to that child. And so we really do want you to go off of the orders. And if you're having issues with those orders, if they're dropping low, we need to know. The family needs to let us know, because we need to adjust that. As Madison talked about the honeymoon phase, maybe that's a factor. Maybe there are other factors that we need to adjust that insulin. So we do want you to stick to those orders and communicate back with the family what's working and what's not working, because it's a process and it's ever evolving and ever changing. Please do not hold insulin, adjust insulin, or split doses for fear of the amount of insulin prescribed. I know I worked on the adult side before I came over here, and they had puny little sliding scales. I don't even know what we really did with adults, but our kids need the insulin they're getting, especially if they're teenagers. They may be on a pretty high insulin to carb ratio because of everything that's going on with their growth and their puberty status. And so that is tailored to their needs. And again, if you're having lows, if you're having issues with that, we need the parent to communicate that with us. And even if it's a large dose, do the calculation again. Maggie gave an example in the last session of if Johnny ate 118 grams of carbs or something, the more carbs they have, the more insulin they're going to need. The higher their blood sugar, it's going to be the higher the insulin needs. So just keep that in mind. Maggie also talked about in the last session our day 2 class. So all patients prescribed mealtime insulin will be scheduled in a day 2 class, typically 2 to 4 weeks of initial diagnosis. Now, all of our classes are part of an ADA program here at Bonheur, so they do require a referral. This class is definitely most effective when paired with a provider visit. And so definitely this is going to go hand in hand with their medical care. So their education goes hand in hand with their medical care and things of that nature. And so if you had a patient that was being seen at an outside facility, it would be a little bit hard to kind of get them into this education. They may have to be provided education somewhere else, especially for this class, because it's so closely intertwined with our doctors. These are our education topics that we go over in this class, the biggest thing that you need to know is that typically these are going to be the times that the patients are transitioning to utilizing that insulin to carb and correction factor dosing for their meals. And this is also when we are going to start addressing snacks a little bit more specifically as well. And we also find at this time, this class is either a class of, 2 to 3 patients. And a lot of times we figure out in this class, are they actually giving insulin? Have they accepted their diagnosis? Can they count carbs? We're really kind of breaking down some of those barriers and figuring out what is going to work best for them. So sometimes we do have patients that they can't really wrap their mind around starting dose calculations, and they choose to stay on a sliding scale. And if that's working for them, then we want to support them in that decision and then reassess at a later time. So you may see a patient who you're like, oh, did you go to class? And they're like, yeah, I went to class. And then they're like, did your insulin change? No. And that might be the case for them. So just it's really great to kind of know our process to know where they are with this. And then we have their first provider follow-up appointment. We call that their day 3. And all new onset patients are given this specialty clinic appointment for their first follow-up, typically scheduled 1 to 2 months from the initial diagnosis. And in that session, they are going to see social work, and we're going to figure out some insulin insurance requirements for maybe CGM therapy. That's kind of evolving and changing. So something that you guys are going to need to know is that those continuous glucose monitors like Dexcom and Freestyle Libre, and there's some other brands as well, they are going to be heavily determined by insurance requirements. And so we actually have a nurse who works on those. And so we're learning more and more about how to get those quickly for patients. So you can always tell the family, hey, have you thought about, pursuing the Dexcom or CGM therapy? There's definitely going to be heavy costs sometimes with commercial insurance patients. So it's definitely a family choice. But definitely at day 3, we're looking at, do they have a CGM? Do they meet the requirements? Are there things that can work towards that? Another big thing that's going to be important for you guys to know is that this is when we prescribe and teach insulin pens. So I know that insulin pen therapy is typically a little bit easier to maneuver for both our patients and our school nurses, but we do typically start out most of our new onset patients on vial and syringe to make sure that they can master that skill, because they will have to utilize vial and syringe at times throughout the course of their diabetes diagnosis throughout their life. So we definitely want everyone to have mastered that skill. One big thing that kind of comes with that that's going to impact you guys as well is that the insurance only gives them a certain amount of fill for 30 days. So they may have 1 vial and when they are diagnosed. Now, that might kind of depend, but they may have to travel back and forth with that. The same goes with the pens. They're only given a certain amount. So you're going to have to work with the parents to figure out how you're going to maneuver those supplies because of the insurance needs here in the beginning. Of course, insulin pens typically come in a box of 5, so it's going to be a little bit easier to take one to school and maybe have one at home, but the vials are going to be a little bit different. And of course, at this time, nurses are going to reinforce topics from previous education classes and assess for needs. That's constantly going on. We're constantly assessing these needs. The last class of our new onset program is going to be our Diabetes Basics Complete, which is our day 4 class. And this is going to go over a ton of really great resources and topics within the basics of diabetes care. And so this is going to be for every patient that's diagnosed with diabetes. And then we do have some additional classes as well. So we have some self-management classes as well as our insulin pump class, our diabetes refresher class. So if there's an additional caregiver that is coming into the picture and is caring for a child and you guys recognize, oh, grandma or uncle or something of that nature, then this is a really great class for them to attend. And so you can kind of maybe put a bug in their ear. And then the other classes are very specific topics, but they are more advanced classes. So that's kind of where we are. I'll just run through these real fast. We do have some awesome website resources. These are our links to those websites. And then on our website, there are some helpful handouts, some patient handouts, blood sugar logs, education videos, articles, webinar recordings, all of these things. We've got tons of information out there. That website will be updated a little bit later this year as well to be more user friendly. But there's tons of great stuff on there for incoming teachers, other caregivers, things of that nature. So we have all of those things available to you. And we actually took up the entire time for this presentation, which is awesome because I don't think we had any questions. But we're really glad that you attended this session. We're going to go ahead and end this session, give a little break, and we'll be back at 10:45 in session 3.
We're registered users.